So thank you very much. I am super honored, humbled, and thrilled to have this opportunity to share a training program that we developed at Transitions LifeCare about 3 years ago. So I work in the education department, and I'm a nurse educator and informatics nurse as well. And our education department came up with the training program because we obviously felt like the empathy asset as a caregiver, as a healthcare provider, was super important. So I'm going to use Brene Brown's description of empathy because I think it goes more deeper than just talking about the differences between sympathy and empathy. So Brene Brown says that empathy is a choice, and it's a vulnerable choice. In order for you to connect with someone, you have to connect with something in yourself. Brene Brown is a lecturer, is a professor, and she's done TED Talks, and she studies complex emotions and behaviors. And further, empathy really is compassion in action. You are actually showing through your behaviors that you are interested in finding out more about what this person is trying to communicate. Empathy drives connection. And the other thing that we really don't think about often is that empathy has other incentives. If you're a provider, you're going to incur less lawsuits if you have a good bedside manner. I mean, think about it. Who of us wants to go see a provider who does not show compassion as a healthcare provider? And I'm going to show you a short video that Brene Brown also did, which I think it says everything without me having to say more to describe the difference between sympathy and empathy. And it's brief, so it's a really good training tool if you decide to use it in your organization. Can you not? Well, it's not started yet. Can you hear it?
Empathy.
There we go.
Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, I'm down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. At least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
So I don't think, if you've not ever seen this video before, if this is the first time you've seen it, for the next couple of weeks, you're going to be very aware of when people say, at least, you're going to be like a cat on a rat. It'll make you so mad. So empathy is feeling with people, and sympathy, again, is like feeling pity for someone. And in the video you saw where the person just completely shut it down and said, hey, you want a sandwich? So why are we making a big deal about empathy? What is the big deal? Well, it really is having empathic qualities in your behavior really is linked to a higher EQ, or emotional intelligence. And being able to teach empathy, we feel in our organization, is best accomplished through experiential learning, participative learning. I remember earlier today when Mary discussed their simulation program, that is really a much more superior way to learn things. We feel like all of healthcare providers need to make sure that their staff are able to demonstrate empathic behaviors. So this is part of our onboarding, and started out as a class for all new employees. So we get new employees once a month, and we would put them through this class as part of their week-long in-house orientation program before they actually went out with their preceptors out in the field. And we felt like this is an important part of the employees needing to explore their own skill sets so that they do have the ability to provide high quality care and better patient outcomes. We know that with empathic behaviors, there's better communications between our patients and their families. So how did we do this? And of course, this was pre-COVID that we did all of this live. And now we have to provide as much of this virtually as we can until it's safe again for our new hires to start coming into the office for in-person orientation. So we would gather our group together and do a pre-exercise survey, asking them what they thought about end-of-life symptoms and diseases, and whether they thought that they were empathic, if they had a natural empathy. We would do that first. And then we would start simulating certain disease processes. And then at the end, we would also have a post-exercise survey and discussion. And the pictured here is our CEO, John Toma, and he's doing the straw exercise. So with the straw exercise, we have everybody unwrap a coffee stir straw. And when we give them the cue, we ask them to breathe only through the straw for 1 minute. And during this time, they just breathe through the straw, and then we tell them to stop. And we actually discuss what it was like for them to breathe through the straw. And interestingly, a lot of people say they have anxiety while they're breathing through the straw because they can't get enough oxygen in, and it triggers anxiety. And back in 2011, our agency was involved in a 3 other hospices and us that was looking at whether we could actually collect data from hospice and palliative care patients. And one of the unintended results of this study is that patients on a scale from 0 to 10, so like they were having pain, they could get to about a 4 or a 5 on the pain scale before they started feeling anxious. But on a shortness of breath scale, they could only get to about a 1 or a 2 before they started feeling anxious. So that tells us that having shortness of breath and respiratory problems is very disabling, and people suffer greatly with shortness of breath. What we did after that is we had them come out of the room, the conference room, out into the hallway, and we started putting on some equipment that would help us simulate other disease processes. So we've already discussed the straw exercise that's done first. And then what they would come out and we would put goggles on them that are scratched up and then yellowed out to simulate what it might be like to look through the lens of a cataracts patient with macular degeneration as well. We would put 20-pound weights on their ankle and the same corresponding arm on that side. We put 10-pound weights. We would take IV bags, and they were 5-pound bags, I believe, and we would put those in the apron. We have an apron with pockets. We would put them in the pockets and then put the apron over their head. We would ask them during the, after the equipment, that we would give them a memory exercise type task, which you'll see in a minute. And we put headphones on them that has background noise to simulate hearing loss and background noise, and also contributes to the dementia. And the last thing that we would put on would be some gloves that have rubber tips to simulate what it might be like to not be able to use your hands and feel very well, like if you had untreated, long-term untreated diabetes. Now, it would not be at all unreasonable or uncommon, especially with our hospice patients, but also palliative care patients, to have multiple disease processes at one time. For example, we might have a patient who had a stroke 20 years ago. They had another stroke last month. They have suffered from hearing loss, problems with their sight. They might have smoked. I mean, this generation now that are old and frail, just about all of them smoked. So they have lung damage. They come to us with end-stage COPD, and then they also may have a cancer diagnosis and they become eligible for hospice. Fortunately, we were able to get one of our local affiliate TV stations to come and film this experience. So what I'm going to have you do is I'm going to show you a film. And as viewers, I would like for you to make yourself vulnerable. I would like for you to pretend that you are the lady in the video going through this experience. And the way the video is done, it also gives you a glimpse of what it might look like to see through the goggles or not be able to see through the goggles. So I want you to use your imagination like you did when you were a kid, and you're the lady in the video.
I'm going to put this apron on you. I'm going to tie it in the back. I'm going to add some fluid to your abdomen, to your lower belly.
Okay.
Because you've got pancreatic cancer. Oh. And when somebody has pancreatic cancer, they build up a lot of fluid in their stomach and in their abdomen, and they walk around with all that extra weight on them. You also have cataracts and macular degeneration, and they can't really do much medicine. Cataracts are getting...
I'm going to stop this for 1 second because I forgot to tell you something that is important. This video is also taken with the idea that she is in a facility. So when she goes in the room, there's going to be facility staff, if you will. And although a lot of cultures are different in the United States, unfortunately, sometimes staff in facilities, whether it's long-term care, hospitals, sometimes forget and are insensitive to the needs of our elderly and frail.
Getting worse and worse. So your vision's getting cloudy. And that's... Also, you're losing your hearing on top of all of that. So you're having a really hard time with background noises and trying to distinguish what everybody's saying. And then you also have diabetes that you haven't taken care of. And when you don't really take care of your diabetes, your nerves begin to get all damaged and die off, and you're getting what we call peripheral neuropathy in your hands. And you're having a hard time feeling things and picking stuff up. And now you're going to go straight through to Mark.
Okay, I'm going to lead you to Mark. He's going to give you a stroke. Oh my.
So Nicole, are you right-handed or left-handed?
I'm ambidextrous, but dominant left.
Dominant left. Okay, well, you've had a stroke and it's going to affect the mobility on your left side. So you're going to have some weakness here, as someone would with a stroke. You'll put your left foot forward a little.
I'm just going to steady you.
Okay. Always going to give you some instructions.
All right, now Nicole, come with me, and we're going to go in this room, and there are 5 tables in this room, and you have a minute at each table. The first table, you're going to match the socks. The second table, you're going to make 38 cents change. The third table, you're going to set the table for 4. The fourth table, you're going to pour 4 glasses of water, and at the 5th table, you're going to read and sign your consent form. Got it?
Okay.
Okay, come on in here, honey.
Oh,
This is Nicole.
Oh, hey,
And
honey.
We found her blood pressure pills under her pillow.
my
gosh.
She
spitting them out.
She does that all the time.
We think she's had a second stroke.
Yeah, it doesn't surprise
you
me.
know, I don't. She will not listen.
No, she just.
spit them at somebody the other day.
Yeah,
She don't like
just-
her medicine.
She doesn't like it. She just calls. Here you go, honey. Here's your stuff. There you go. Remember what you did. Now you did this before now.
Yeah.
Yeah.
Good job.
Okay.
So, are you working this weekend?
No, I asked for it off.
Oh, I want to see somebody.
Well, I cannot fold these. I think I'm supposed to be folding clothes here.
Wait, you did this before. You just gotta try hard.
Well, I can't see what I'm doing.
There you go, honey. There you go. This is your other thing, right there. Yep.
38 cents of change, you told me?
Whatever she told you, what you want for yourself. All right, table's right in front of you.
Setting the table? Okay, so we've got bowls, plates.
There you go, right there.
Right there, what? That's a glass. I think I need to.
Here you go, right there, remember? That's right, you did this before, now you just gotta try and you can do it.
Labs are bad too, so she's probably not a surgical candidate. I don't know what we're gonna do with her.
She ain't gonna be here long.
All
All right, now honey, this is for your, consent that you're gonna have surgery, and they told you all about it, and they told your family about it.
But I can't see.
It's right here, honey.
But what does it say?
You just put, oh, okay, I'll get her.
But what does it say?
It's just telling you about your surgery, and you just need to put your name right there. They already talked to you. I don't know if the family's coming. No, they're bad.
They're just gonna have to go ahead.
Right up here, almost, right here. There you go. That, just put your signature.
They're ready for.
All right.
How'd that feel?
Strange. Not good.
That was only 5 minutes.
It felt like an hour. And you guys were not being very nice, talking about me as if I wasn't there. I think the thing that got me the most was not being able to see. That was it was really hard to see. And then remembering all the instructions you gave me. The stroke was that would be exhausting after a while to have a limp limb like that going over and over and over again. And then kind of talking about my conditions and the fact that surgery is just not going to matter and I'm going to be dying anyway. And, you do hear those things in healthcare settings a lot. You hear people just talking about people as if they don't exist, and even people when they're dying as if they're not in the room. So that's very sad, and I'm super glad that you all do this because it's a big problem for sure.
And then I'll put
So once everybody has been through this, then we gather back together in the conference room and we have dialogue and we prompt everyone to share how they felt and what that was like for them by asking them these kinds of questions, the open-ended kind of questions. What was that like for you? How did you feel? What did you think about people talking to you as if you didn't exist? Calling them honey and sweetie, which in our state, North Carolina, is a violation. You should always call someone by their given name or the name that they choose to be called. What was hard for them, and what would you do differently as a caregiver? And also asking them if they feel like this is an effective training tool for them, an empathy enhancement type training tool. And what we found was that a lot of people in the group would have strong reactions. Some people got emotional, which is really what we wanted to see happen, because if you think about it, anytime you've attached an emotion to a memory, you're going to remember that for a long, long time. If you think back to when you were a child, I mean, heck, I'm like 60 plus, and I still remember very vividly a couple of things that happened to me when I was 5 years old, because there was strong emotions attached to that. So a lot of people were evoked by this experience, and a few people cried, and they shared that this experience really made them feel dismissed and sad and disrespected on so many levels. They experienced anxiety and agitation and felt like they were just a burden, felt quite devalued, desperate, scared, and panicked. And they shared their reactions. We actually had 2 TV anchors come and experience this class with us. And when we came back in the room to do our dialogue and debriefing, one of them tossed his glasses on the table. Kind of surprised me. I wasn't sure what I was going to do with him. And what had happened was, the week before, he was informed that his sister, who lived in another state, had just been diagnosed with early onset dementia, and she was a teacher, and she was going to have to quit school, and he was very, very upset about that. So that was something that had just recently happened to him. So he was really, really impacted by this class. And we kept some statistics on the class. So we would do the pre and the post survey, and I collected data for 10 months, and we had a total of 101 new employees during that time. And we had a 0% dropout rate. So we gave everybody the option, even during the session, if it was too uncomfortable for whatever reason, they could opt to stop. But we didn't have anybody drop out, so everybody was a good sport. And 96% of all of our participants indicated that they strongly agreed that they had increased empathy and understanding of end-of-life symptom burdens from the symptom simulation program. We had one senior medical student that was in the program that actually wrote a letter to his dean indicating how powerful the experience was for him. So I'm going to end by just reading an excerpt from this medical student's letter. He said, although the whole exercise lasted about 5 minutes, it completely changed my perspective of patients, especially elderly ones. It fundamentally challenged how I thought of patients, and it most definitely changed how I will administer care for them. I can't emphasize enough what a lasting impact this simple simulation left me. So does anybody have any questions?
Thank you. That was a wonderful presentation. Yeah, if anyone have any question or comment.
I don't have a question necessarily, but I do have a statement. It's Melissa. Me and one of the educators in our health region, actually, we did a presentation on living like with dignity and dying with dignity. So I did the dying part and she did the living part. And it's interesting because we actually did some of those things that you mentioned about like giving the people that participated, like the nurses in our group, and it was all for long-term care to start. We just were doing one session. We were asked to do it. We combined their presentation. We didn't think it was a big deal. And we did what you did. Not everyone though, so I learned some from you. And we got the same reaction, and people were really emotional because they work in it all the time in long-term care. And then we got requested to do it so many places that we couldn't keep up. Yeah. And then we had to go to acute care because then they heard about how, because of the emotional, like you say, response, people couldn't believe how powerful it was just pointing out simple things like how you were, but just in living and in dying, with just that respectful empathy was, yeah, so good job.
Yeah, thank you for sharing that. We had the same reaction. We were asked then to start taking it in the community, and somebody mentioned volunteers earlier, and I was wanting to let you know that we trained a bunch of volunteers to help us with this program, because as you can imagine, it's very staff intensive to run this program. When we started going to assisted livings and long-term care facilities, and we had to pack all that stuff in our car, it takes a lot of effort, but because we felt like the program was so powerful and we got so much good feedback from it, it was worth our effort. So we solicited a bunch of volunteers from our organization, which we have more volunteers than we have staff, which is supposed to be a real positive for an organization. And we trained them to come with us and alleviate some of the staff intensity.
Well, this was excellent. Did you guys at Transitions make up these simulations?
Yes, we sat around the room and we actually thought about the possibility of having people drink Thicket, but then we thought we didn't want to be cleaning up vomit, so we decided not to go with that one. But there were lots of things that we discussed as a possibility of how to simulate a certain disease as a group, and then started testing them out and tweaking them as we needed to.